Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation with Cancer Experts series, we're back to having Dr. Binod Dhakal on the program, and he is going to now touch on a new topic, which is a recently presented trial, the MIDAS study at the American Society of Clinical Oncology and the European Hematology Association meetings. And this is a trial that garnered a fair amount of interest. I put up a provocative title saying, "Is this the end of transplant?" And so, who else can better opine on this than Dr. Dhakal, who's done some of the pioneering work in myeloma in recent years? So, welcome, Binod.
Thank you, Ravi. Thank you for having me.
So, can you tell us what the clinical trial that we're going to talk about today, what the trial design was?
Definitely. So MIDAS, as the name stands, Minimal Residual Disease Adaptive Strategy Trial, which is based on the MRD, using the different consolidation and maintenance approach. For example, here this is a phase 3 randomized study. Patients get uniform induction with ISA-KRD, which is a quadruplet regimen for 6 cycles, and based on the MRD, they are either randomized to either for those who are MRD negative of 10 to the power minus 5 and standard risk, they are randomized to either ISA-KRD for additional 6 cycles or get autologous transplant followed by 2 cycles of ISA-KRD consolidation. And both of the arm will get maintenance lenalidomide for 3 years. In the other group, which is of course a high-risk group where they still have MRD positivity at 10 to the power minus 5, they are randomized into either autologous transplant or followed by ISA-KRD consolidation, or the 2 transplant or tandem autologous transplant, which is usually done in Europe for the high-risk patients. And after that, they get both of the group get iberdomide for 3 years. So this is a risk and response adapted therapy in a sense, because these patients, it's kind of looking at the dynamic risk model. After 6 cycles, if they don't clear the disease, or if they clear the disease, then either you go more intense treatment or less intense treatment, and look at the outcomes after that. The primary endpoint of the study is looking at the MRD negativity rates after consolidation. For example, for both the groups, it is after consolidation, means either after transplant or tandem transplant in the other group, or ISA-KRD consolidation in the group 1.
So it seems like the major emphasis on this presentation was on arm A and B. We'll talk a little bit about arm C and D, the high-risk group, but it was the standard risk group that was the major focus of the trial and some of the discussion that ensued. We don't have any data, I think, at the moment on the post-maintenance phase, as you said. So we're talking about the data post-consolidation. So there has been some previous presentations on the trial. So just to lay the groundwork, can you tell us what we have known so far before this presentation?
Definitely. So prior to this presentation, there is initial data looking at the MRD negativity rates after induction. As I said before, this is the more or less transplant eligible patient. They cut off the age group under 66. So usually it's what usually is done in Europe. We probably have a little bit higher bar in the US. So they are all transplant eligible patients, and these patients get 6 cycles of ISA-KRD induction. The initial data was presented that showed the MRD negativity rates after 6 cycles, and you can see the MRD negativity rates at 10 to the power minus 5 was 63%, and at 10 to the power minus 6 was 47% intent to treat patient population. This is quite impressive data that clearly tells you how deep responses that we can achieve with this quadruplet regimen using CD38 and carfilzomib-based combination. So I would say this is, compared to other results, other quadruplet data we have, the MRD negativity rate seems to be quite high here. What is impressive here in the initial data is looking at the cytogenetic profile and looking at the MRD status here. Interestingly, as expected, patients with the translocation 414, had higher MRD negativity rates with this quadruplet induction compared to those who are negative, which is kind of a little bit surprising here. I thought that this is the high risk where the patients probably would have less, compared to the patients who didn't have the translocation 414, they probably have less rates of MRD negativity, but that is quite significantly different. And on the other side, there's those patients who translocation 1114 who are negative, they have higher MRD negativity rates. So that is positive patients who have low rates of MRD negativity. And perhaps this is something that we only need to look at the longer follow-up and how they span out in terms of the longer survival outcomes. But this is a little bit of interesting observation at this point of time.
So I think we kind of have talked about how the assignment was, and we'll move on to the demographics of the patient accrued. So can you tell us about what were the highlights of the population on this trial?
I would first say that this is a very large study, almost 1,000 patients, and it's kudos to the investigators for doing this large-scale study in a very short period of time. So that is the really kind of important achievement for this large, randomized study. I think in terms of baseline characteristics, I would say this is pretty standard. All the groups are pretty well balanced in terms of the basic baseline characteristics. For example, age, performance status, IST3 disease. In terms of the cytogenetic abnormalities, as you can see, the 1114, which is usually present in about 15 to 20% of the newly diagnosed myeloma, may be a little bit higher in the arm D group, and arm C, which is like the MRD positive group. So that is consistent with what we saw in their induction report of higher, lower MRD negativity rates in the translocation 1114. So by design, they were randomized into this second group with the most intensive treatment. Almost half of the patients at 1114. Beyond that, I think if you look at the cytogenetic profiling, including the high-risk cytogenetics, they're pretty well balanced across the group. So that means, the high-risk, beyond the 1114, the other cytogenetic profile didn't impact the MRD negative rates, and hence the randomization in that particular groups. In terms of the MRD negativity at 10 to the power minus 6, you can clearly see they reported the arm A and B, and this looks, quite, impressive as well in that group, which is pretty high number of patients did achieve MRD negativity 10 to the power minus 6. So I would say, in terms of the baseline characteristics, which is this looks pretty consistent with what we would expect in this newly diagnosed patient population.
And what do we know about the primary endpoint of the study?
So the primary endpoint is the post-consolidation MRD negativity. That means, either they looked at the MRD negativity after 6 cycles of additional ISA-KRD in the one group versus transplant followed by 2 additional cycles of ISA-KRD. So you can see this is at 10 to the power minus 6, which they reported, and you can see the MRD negativity rate 76% in the ISA-KRD only group versus transplant group is 73%. And that looks quite comparable. And so this is a very important findings that we see, that to see that the initial MRD negative rates after consolidation did not differ between those two groups.
So obviously at this meeting, as I said, the major focus was on arm A and arm B. So no data on arm C and D was presented at this meeting. What about subgroup analysis? What have we learned on arm A and arm B?
Yeah, again, MRD is the early endpoint. Conventionally, what we have been seeing with the prior studies are that the patients with the high risk, and there are certain groups that we really benefit from the transplant. Fortunately, in this study, or unfortunately, we didn't see any major differences in the subgroups. They pretty much look pretty much similar. For example, one of the things that I would like to focus is on high-risk cytogenetics. You can clearly see the curves kind of overlap. They cross the midline. Similarly, the patients with more than one cytogenetic risk, they also, you can see that they still cross the confidence interval of 1. So in general, when you look at this subgroup analysis, there is no any particular subgroup that you could argue that this one method, either a transplant or no transplant, really benefits that significantly, because the p-value seems to be non-significant for all these subgroups. So again, this is very important observation, that can be derived from this analysis, is that at least post-consolidation MRD negativity doesn't seem to be differed by any of the disease characteristics.
And what about arm C and D? Though we didn't have any primary presentation, there was a subgroup analysis presented.
Correct. So the primary MRD negativity rates on these subgroups were not reported. But if you look at the subgroup analysis, here also the similar story. And I think it's very, very important, especially for European colleagues who still were doing the tandem transplantation for high risk. In the US, I think that has already been fallen out of favor because of the stamina study results. But here you can see there are no particular subgroup that really benefit from the second transplant. We saw in EMN study those patients who received Cybo-D induction. In those subgroup, we saw the high-risk patients did benefit from tandem transplant. But I think this really changes that paradigm or that thought process that if you have a very effective induction, and if you achieve a very good responses, including deep responses, adding second transplant in the subgroup didn't really matter, even in the patients with high-risk disease.
So what do we know about the trends in how the MRD trended over time?
I think this is an important study, I would say. I mean, important results. This slide is important. I just looks at the flow of the MRD negativity from induction to consolidation. As you know, in arm A, these patients got 6 additional cycles of ISA-KRD. And if you look at the MRD negativity rates, especially looking at the 10 to the power minus 6, it went from 76% to 90%, quite impressive. And here in the arm B, which is a transplant group, I should say, it went from 70 to 93%. So it looks like numerically you are getting higher MRD negativity rates in at least the deep MRD negativity rates in transplant group. But overall, that numbers look pretty comparable. So at this point of time, we know that they look pretty much the same. But as in all transplant studies, I think it's important to look at the follow-up. So once we have a longer follow-up, we might see if there is any difference in the outcomes, like if there is separation of the curve down the road. But we also know that MRD, post consolidation MRD, is a very good prognostic marker for PFS. So we may not see the difference even with the longer follow-up. So, but this is a little bit of interesting to see the numerically higher percentage of deep response in the transplant group. So I would say that this is an interesting observation. We'll need to see a little bit longer follow-up.
And what about the MRD status according to the 1114 translocation?
Yeah, so if you just look at the 1114 translocation, as shown in the induction, where you didn't see a lot of higher MRD negative rates with the translocation 1114, the deepening of the responses was much shorter or much smaller in magnitude than patients who didn't have 1114. And we see that, in the transplant, in the conventional treatment as well, they don't seem to have a deep responses, even with the transplant for 1114, even with this induction treatment. Sometimes, you're surprised when you're giving the induction with the DARA-VRD or other quadruplet, you don't see the same depth of response that with the other cytogenic subgroups. And that is probably what is reflected here as well. And if you have transplant 1114, you probably don't deep, but whether that is something that is going to, translate into long-term outcome, that is something we have to see, because, the importance of this is that we have now new BCL2 inhibitors in clinical development, and that might call for investigating these new agents in combination with these therapies in the frontline setting in induction, see how much we can deepen the response, and perhaps that can, translate into better PFS outcomes with longer follow-up.
So what's the bottom line? What's the takeaway from this study?
Yeah, again, this is the first of this large randomized study done. Again, it's a French group did this fantastic, endeavor to, to treat or to adapt the treatment based on the response by MRD, which is what is going to be the future trials going to look into that. This, for the first time, we saw that there is no difference in the post-consolidation MRD negative rates if you have a very good induction and consolidation, which that is a very important observation. In terms of that, how much that can translate into practice, I would say that we probably need to wait for a little bit longer follow-up in that. And similarly, the tandem transplant is something that we're still kind of question in the context of novel induction, especially the quadruplet induction. I think this clearly tells that adding second transplant in those patients don't really increase the depth of response, and perhaps may not translate into longer, better outcomes. So, but with the caveat that this is a shorter follow-up in both the groups, I think probably have to wait a little bit longer to see the the survival benefits, or if there are, or if they're not. But at this point of time, I think the results are quite convincing to say that perhaps the transplant is not needed in the patients who really achieve deep responses, those standard risk patients. And for the high risk patients, the second transplant is not going to be useful. Probably need to think of something more or beyond adding another transplant, right? Perhaps think of some novel strategies.
So I think that again, the discussion that followed this, the panel discussion, did feel that it was a little bit premature to abandon transplant for standard risk disease, because first of all, sustained MRD negativity is what really is prognostic, and this was a 1 point MRD analysis. And the other thing is, other trials in the past, like the Forte study, initially showed no difference in MRD in the transplant versus standard risk group, but with longer follow-up, that sustained MRD rates became different and transplant still held up. So I think that what is your take on that?
So that's actually fantastic. I was about to bring that the Forte trial. Actually, Forte trial, as you just said, exactly showed the same thing post consolidation MRD negative rates. Of course, there are three arms there, and in the arm with the transplant and the KRD, I mean, the MRD negative rates are similar in 60%. But when you look at this follow-up, longer follow-up, the sustained MRD negative rates were much higher in transplant arm, and that transplant better PFS benefit. So I think it is quite interesting observation at this point of time. This is something in the large scale setting, which we saw this, but as I mentioned before, I think we probably need to a little bit longer follow up to really say that this transplant is something that we don't need to do for the standard risk patients.
No, I think that obviously we'll be having more follow-up, and I hope that we can return in the future to talk more about the more mature outcomes that we will see with time. But I wish to thank you very much for taking the time to go over this important study, and I hope I can have you back for a future discussion on this and other topics in the future.
Thank you so much.
Thank you.